Now that we are done with the inhibitors of cell wall synthesis, now we'll see the antibiotics that deal with bacterial protein synthesis. We know that protein synthesis occurs in the ribosomes, and ribosomes are made up of 30S and 50S subunits in the bacteria. So here we have two targets. The antibiotics that act on the 30S ribosome to inhibit bacterial protein synthesis are aminoglycosides, tetracyclines, and glycylcyclines, while the antibiotics that act on the 50S ribosomes are macrolides, ketolides, lincosamides, streptogramins, oxalidinones, and amphenicals. In this lecture, we are only going to see aminoglycosides. Structurally, aminoglycosides are sugars. That is, they are made up of two or more amino sugars that are joined in glycosidic linkage to a hexose nucleus. Now, as it is a sugar, that means it is water soluble, right? And water soluble makes it unlikely to be absorbed in the GIT because it's polar, so we need to give it IM or IV. Due to the same property, that is, it is water soluble, it cannot cross the blood-brain barrier and it will be excreted unchanged in the urine and not metabolized by the liver, so we need to adjust its dose in kidney failure patients. Aminoglycosides act by binding to the 30S subunit of the ribosome and thus interfering with the initiation complex formation that is formed by the 30S ribosome, the formyl-methionine transfer RNA, and the messenger RNA. It also causes misreading of the genetic code that leads to synthesis of non-functional proteins or premature termination of protein synthesis. It also breaks up polysomes into monosomes. This is a 30S subunit of the bacterial ribosome, and this is the messenger RNA, which will be read in 5' to 3' direction. Suppose we have a codon such as AUG and GAA. AUG will be the start codon, and GAA is, for example, another codon which will encode for a specific amino acid. Now, if the aminoglycoside attaches to this site on the 30S ribosome, what will happen is that this messenger RNA will form a kink over the area where it is attached, and this will cause a shift in the frame of the reading sequence of the messenger RNA, and now this strand will be read as AU, which is not a complete codon, and the next will be GGA, and this GGA will encode for another amino acid that was not meant to be here. Instead, there should have been an amino acid for GAA. So in this way, there will be production of non-functional proteins and even protein synthesis termination. Now, how does the aminoglycoside enter the bacteria? We've discussed previously that the cell walls of bacteria contain porins. There are pores in the cell membrane that can let the antibiotic enter. But this will enter into the periplasmic space. From there, it will encounter the cell membrane. Now, cell membrane has specific pumps known as proton pumps, but they are oxygen dependent. So they need oxygen to pump the aminoglycosides into the cell. So the bacteria that do not use oxygen, that is, they are anaerobes, they will be resistant innately to aminoglycosides. Thus, their spectrum of activity will include gram-negative aerobic bacteria. They can include many bacteria such as Pseudomonas, Klebsiella, E. coli, and Proteus, etc. They also have cidal activity against some gram-positive cocci such as Strep viridans and Enterococcus. They are also used in tuberculosis and some other gram-negative infections such as bubonic plague, tularemia, and brucellosis. Their drug of choice is primarily streptomycin and gentamicin. They are also used topically for gram-negative skin infections, eye or ear infections. Many modes of resistance have also emerged for aminoglycosides, and they can include drug inactivation by bacterial conjugating enzymes which conjugate them and eliminate them. They can also include decreased entry through the porins and also decreased affinity to bind to the ribosomes. Now, one thing you really need to understand and remember about aminoglycosides is that they have a concentration dependent killing effect. That means the higher the plasma concentration, more of the bacteria is killed rapidly. That's why their dosing contains one dose daily regimen. Because if the total daily dose is given as a single injection, it will reach higher peak plasma concentration and thus maximum effect will be achieved with a single dose. This will also decrease the side effects because there will not be a constant therapeutic level of the drug for a long time. They also have a post antibiotic effect. That means that their effect is even there with blood levels that are less than the minimum inhibitory concentration. That is the concentration that needs to be there to inhibit or kill a bacteria. Coming to the side effects, aminoglycosides are strongly associated with ototoxicity, that is due to damage to the 8th cranial nerve and vestibular and cochlear dysfunction. The risk factor can increase in elderly patients and repeated doses, and also patients with pre existing auditory impairment. They also possess nephrotoxicity and especially neomycin. So you can remember this by the first two letters of nephrotoxicity and neomycin. They also have a neuromuscular blocking effect, just like botulinum toxin, by inhibiting acetylcholine release. This is an important point to remember. Rarely it can cause hypersensitivity reaction because it also is derived from actinomyces, right? It should not be given in pregnancy because it can cause ototoxicity to the fetus as well. Finally, the drugs are streptomycin, gentamicin, neomycin, flumycetin, amikacin, tobramycin, paromomycin, and natilmycin. Now we'll remember a little bit of something about each of these drugs. About streptomycin, I need you to remember that it is a first-line anti-tuberculous drug and it is the drug of choice for tularemia, brucellosis, and bubonic plague. Gentamicin is not effective against tuberculosis, but it is effective against gram-negative rods and gram-positive cocci. Neomycin, as I previously said, is nephrotoxic and it is used only topically. The reason being its nephrotoxicity. And the topical ointment usually contains bacitracin and polymyxin B with it as well. Flumycetin will resemble neuromycin in its nephrotoxicity, so it is also not used systemically. It is only used topically for eye, ear, and skin infections. For amikacin, I need you to remember that AMI or AMI stands for mom, right? So mom has the broadest spectrum of activity among all the aminoglycosides, and it is also resistant to enzymes, bacterial inactivated enzymes. It is useful for the treatment of tuberculosis and also nosocomial gram-negative infections. Tobramycin is just like gentamicin but is better at Pseudomonas aeruginosa infections. Paromomycin is good against protozoans. You can remember that by P because none of the others that I mentioned here have P. So P for protozoans. These protozoans can include intestinal amoebiasis, giardiasis, etc. Next is, or last one is natilmycin, and this is resistant to inactivating enzymes and it is special activity against gentamicin resistant bacteria. That's all about aminoglycosides, the first one to inhibit bacterial protein synthesis.